Hello, good morning. I'm Ashok Kurokode, consultant rhinologist and anterior skull base surgeon from Winchester and University Hospital, Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to the second day of inaugural Winter Global Rhinology and Skull Base Surgery Webathon. Global Rhinology Network is a non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We had hugely informative and engaging 15 sessions on endoscopic sinus surgery presented by eminent rhinologists and skull base surgeons on day one. We'll be having similar sessions today focused on anterior skull base surgery. This event is hosted at the Global Telemedicine Studio of Professor Wilco Grolman in Utrecht, the Netherlands. It is supported by Medtronic and Karl Storz.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing StealthStation Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with StealthStation Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Mindful that you've got another commitment soon after this, I'll pass the mic over to you. All yours.
Thank you. First of all, congratulations for a great organizing a great meeting here via Zoom. And congratulations to all the prior presenters. They have been really amazing presentations. Can you see my screen?
Yes, we can. Thank you.
Excellent. So let's start talking about carotid injury. First of all, I would like to give you some principles of management that may be helpful not just for a carotid injury, but for any other complication. It sounds like a cliche, but prevention is really key to really get away with when you are facing a complication, especially a catastrophic complication. So we are going to talk about things that you can do to prevent or factors to consider that you can use to prevent a catastrophic complication, especially a carotid injury. The other issue that I always emphasize is that you have to have a plan, meaning that you have to think about what are you going to do when you're facing such a complication. This happens really very fast, just like any other catastrophic complication. So if you wait until it happens, you may not have the time to think about something that will give you the best outcome.
Another issue that I always emphasize to my trainees is that they have to think before they act, because complications beget complications, and one thing goes wrong, another one goes wrong, and everything gets complicated. I have never seen a major complication that came as a result of a single factor. It's usually several things that add together to get you to that complication. And once you see a complication, it is good to analyze it in the same way that the aviation industry analyze all the accidents that they have regarding planes. Is you have to learn from your mistakes, and even better, learn from the mistakes of others, because you won't be emotionally involved, and it will be easier to analyze the situation in a more objective way. So if you have a carotid injury, anything that of the listed results can happen. If you're a lucky person and your patient is a lucky person, maybe nothing happens. But if you look at the literature, and this was provided by courtesy of Rowan Valentine and PJ Wormold, you can see here that in 2009 there were 54 carotid injuries reported in the literature, and about 40% of the patients did fine. Nothing happened after the carotid injury. However, another 40% had a stroke, and the rest of them, that 20%, 10%, just basically died of the event. So if we look a little bit about how this happened, you can see here that something that you would expect intuitively is that the more experience you have, the less likely you are to cause a carotid injury. However, the more experience you have, that means that you're doing more and more cases, and probably more complex cases. The chance that you're going to see a carotid injury, if you're an endoscopic skull base surgeon, you can see here that it is very high. At least half of all the surgeons that do this type of surgery will face it. So we have to be prepared to deal with it. So the complexity of the surgery has something to do with it. You can see that when we are dealing with cellular lesions, with pituitary tumors, the incidence of a carotid injury is fairly low. It's less than 1%. But once you start getting into transclavial approaches and more expanded endoscopic approaches, it goes high. It goes to exactly 10%, 10 times the incidence, to 5%. That's 1 in 20. So again, this incidence may be even higher because the bias that we have about reporting complications. If you have a single complication, you are less likely to report it, and therefore we rely on the data of big centers. Like, this is a great study from the University of Pittsburgh, my ex-colleagues and my ex-associates there, and you can see here their incidence of carotid injury. They reported it at 0.3, but that's a little bit of an underestimate, because they basically included all cases. So you will have to maybe consider that if you have a CSF leak in the ethmoids, or you're doing an anterior skull base resection, the chance of having a carotid injury should be very low. You are far away from the carotid. So the incidence, again, may be underestimated, and you have to have that into account. So when we are having our preoperative planning, you have to consider what are the anatomy-related risks, the pathology-related risk, the degree of encirclement of the carotid by the tumor, the type of tumor that you are dealing with. Where are you in regards to the learning curve? Are you experienced? Do you have an experienced team? Do you have adequate resources within your institution to deal with this? If you don't have an interventional radiologist or an endovascular neurosurgeon, you may be limited on the cases that you may want to tackle. If you have a neurological ICU, you will have a great advantage over those that do not. So imaging is critical to give you an idea on what are the anatomy and the pathology related risks, and risks related to the approach. How close to the carotid are you going to be in your approach? Are you going to be doing something like what Dr. Prepa showed us before, that you're going to be pushing the carotid artery laterally, or are you going to be far away from the carotid? All those things are important when you're considering your approach. So you should consider the anatomy. We know that the carotid artery bulges in the sphenoid sinus in most of us, and it does it mostly at the second genu, this area over here. You also have to consider that the endoscopic view is two-dimensional. So our eye tends to go to the paraclival carotid, the ascending carotid, which is over here, and this part of the siphon is much more anterior. But when you look with an endoscope, just like this photograph, you can see that we lose that third dimension, so it looks fairly flat. But this area over here can be 2 centimeters anterior to the paraclival carotid, and I think that can be a source of disorientation and a source of injury. To make it even more complicated, in about 1 in 5 of all of us, this area here will be dehiscent, so you're going to have a carotid that is completely exposed. And of course, you have certain pathologies that make structural abnormalities. The classical one is acromegaly, where the two carotids come together in what we call the kissing carotids. This is a study from Juan Fernandez Miranda when we were still at the University of Pittsburgh, and it's a great study. This had been reported before, but basically called your attention that the intersinus septations and intrasinus septations, most of them are not midline, and actually most of them are going to end up at the carotid artery or the optic nerve canal. Here in the G, at your lower left side, is a great example of that. You can see that all these septations go and end up inserting at the carotid canal. This one over here inserts at the carotid canal and the optic nerve, and on the left you have the same. So what that means for you is that you have to be careful when you're removing these intrasinus septations. If don't fracture them, don't rock them, because you may end up with a carotid injury. And I'll show you an example of that in just a few minutes. A lack of anatomical landmarks. If you have a sphenoid that is not pneumatized, definitely you will not see the landmarks as well as if you have a sphenoid sinus that is highly pneumatized, where you tend to see the optic nerves and the carotids much better. However, in these highly pneumatized sphenoids, you have to consider that you're likely to have a dehiscence of the canal. Another issue that we have found is that most of the vascular complications happen when you go into the coronal plane. And it makes sense, because basically if you see the shape of the carotid arteries are really like goalposts. So if you don't pass those goalposts to the side, you will be dealing with the structures that are in the middle, and you will be less likely to encounter the carotid. There are some things that I call very high risk factors, like when you're doing a radical resection of a tumor, especially in malignancy that tends to be adherent, that is adjacent to the carotid. When any tumor that is encircling the carotid more than 120 degrees, lesions that require the wide exposure, just like what Dr. Prepa showed us before, and patients that have had some prior injury of a vessel. Those are very high risk factors. And before we go into surgery with this type of patient, I think that we need to consider non-surgical means. It may be possible that a malignancy you treat it with chemoradiation. It may be possible that a meningioma you can treat it by debulking and then follow by radiation, etc., and you don't have to really submit the patient to the very high risk of injuring the carotid. It may be that you have to, if you have these high risk factors, you may have to be ready to sacrifice the carotid. So you have to assess cerebral circulation. Protective stenting is something that comes up as a question very, very frequently. In theory, this would be a great solution, but in reality, when you do a protective stenting, that means that your patient is going to have to be anticoagulated with antiplatelet therapy and aspirin for a minimum of 6 weeks. And to be honest with you, I would feel much more comfortable with having the patient wait about 3 months. So this means that your case is going to be delayed. The other issue that these have is that stents themselves are very unwieldy. So that means that you cannot put a stent in the siphon of the carotid. It just doesn't pass into that area. The curves, the stent tends to be rigid, so the curves of the carotid tends to impede the passage of the stent. So they have pipelines which are much more flexible, but that will require even more time for that pipeline to adhere to the wall and to be protective. And then you have these extreme strategies that we have to consider once in a while, using rapid infusers and cell savers and even extracorporeal circulation. But that should be really, really extreme and rare cases. So again, the disorientation, I think, is one of the most important sources of critical mistakes. Disorientation because you don't know the anatomy, or disorientation because of the distortion that the endoscope provides. So I would say that the endoscopic sinus surgery or endoscopic skull base surgery is the only surgery where the surgeon can lose where the head and the feet of the patients are. So if you have very close magnification and your camera is to the side, especially with angle scopes, what you think is to the right may be up, and what you think is maybe down and maybe to the left, and that may be a source of problems. Visualization in endoscopic sinus surgery is a little bit of an issue. The endoscopes provide great visualization, great illumination. However, they're very close to the field, so any blood tends to slime the endoscope, and then all those advantages that I mentioned before disappear very quickly. So all these strategies that you see here and others that have been mentioned before, we use them to again try to obtain best visualization possible. The use of visualization adjunctive techniques like navigation are helpful for these patients. The use of a Doppler is also very helpful. So we know that the navigation or the use of ultrasound not only allows us to hear the carotid, but it also allows us to see it. There have been several advancements in the endoscopic ultrasound. So the advantage of ultrasound and Doppler over the navigation is that it gives you live information. And when we look at the navigation system, we're looking at imaging that was done preoperatively. So when we're dealing with bone, the bony landmarks won't change that much from what you had preoperatively to what you have in surgery. But when you're dealing with soft tissue, there will be movement of that soft tissue, and the navigation will be accurate anymore. So for the most part, we use these techniques as a complementary tools. Things that you have to consider. You have to be preemptive. You have to make sure that blood is available if you have a patient that is at risk for a carotid injury. And what I mean by that is not just order a type and cross, it's really see the blood available in the operating room. So when we have a high-risk patient, we want to see that blood at the OR. You can have a cervical prep for carotid control. This is a technique that I use frequently for nasopharyngectomies. And the idea here is that you control both the common external and internal carotid arteries in the neck, just in case you need further control. But I also dissect the internal carotid artery up to the skull base and then protect it with cottonoids on some type of blue sky material. So when I'm coming from the nasopharynx toward the carotid, I find the cottonoids or the plastic material rather than the lumen of the carotid. These patients are prepped on the thigh for a possible muscle patch, and if possible, we use SSEPs and EEG just in case that something happens. We have a better idea of what is happening in the brain. So let me show you a few examples of what is happening here. This is a very experienced surgeon. And basically, the mistake that he makes is that he used electrocautery on top of the sella to gain control of the mucosal bleeding. But what happened in there is that basically that electrocautery also cooked the carotid artery. So when he removed the bone over the carotid, you can see here the end result. You have a carotid injury. Here's another very experienced surgeon. They are trying to mobilize. They are actually at the very beginning of the surgery. They are opening the dura, and you have medial displacement of the carotid injury, and you can see the end result. So this could have been prevented by the use of both the navigation or the Doppler. Another experienced group, what I'm going to show you here is look where they are working. They are working at the rostrum of the sphenoid sinus, and they are drilling the rostrum of the sphenoid. Oh, sorry, I'm trying to advance them to the right point. So as they drill the rostrum of the sphenoid sinus, they're doing it with a cutting burr. And what happened there is that they basically engaged, let's go back for a second, they engaged that septation that I was telling you about. And the septation, because it's a cutting burr, just broke, and it caused a fracture of the carotid canal and a carotid injury. Something, the septation is very similar to the diagram that I'm showing you here on the side. This one is something that probably the surgeon would like to have a second swing at this one. I don't know what the thinking was, but this is a microlead reader. So let's go back so you see it one more time. Using a microlead reader, you find a dehiscent carotid artery, and of course the result is that. Kerrison rongeurs, this is a very common area for a carotid injury. It's a paracellular carotid, and it's due to the use of a Kerrison rongeur. Ultrasonic devices, the company tells you that this is something that is completely safe, that you can do it over the carotid canal. Not so much. You can see here that no tool is completely fail-safe. This is our own injury. All these other videos were provided by different surgeons, for which I am really grateful. But what you can see here is that we're drilling the carotid, and we have the initial bleeding is venous. But as we try to stop the venous bleeding, we realize that all of a sudden it's an arterial bleed, and it's an injury to the paraclival carotid. We'll talk about that more if we have time. The use of cutting instruments, you can see here, the scissors are not very sharp, so the surgeon keeps insisting and pushing harder and harder, until a catastrophe happens. They have a carotid injury. This is also my case. You can see here that we're using an aneurysm clip. This was a mucoepidermoid carcinoma of the nasopharynx, and luckily we knew that the tumor was approaching the carotid, and luckily we had proximal and distal control of the carotid artery, and that's why we were able to put clips. So this has been advocated as one way of stopping the carotid injury. The problem is that you have to have full exposure of the carotid to do that. So if you're facing that type of a scenario, what do you do? Well, if you have an OR similar to mine, you may have a lot of people around. You may have chatter in the operating room from the scrub nurse, the circulating nurse, and anesthetists that are all talking about the weekend and their families and their dogs, and they're not really paying attention to what is happening in the monitor. So you have to remain calm, but you have to call everybody's attention and make sure that they're going to be focusing on the surgery from now on. You have to ask for their help. Remember that you are the one who has to stop the bleeding, so you have to remain cool, calm, and collected. Although you have to be somewhat forceful on the way that you require attention. If you're doing an extradural approach, and some of us are going to be doing these surgeries without a second surgeon, if you're doing that and you're extradural, nasal packing may be an option, and it may save the day, and it may give you time to think about what else you're going to do. However, if the dura is open, nasal packing is not an option. If you put nasal packing with the dura that is open, what will happen is that the blood will track into the brain, and you will not have a good outcome in that patient. So you can, again, if you have two surgeons working at the same time, the best approach is really to assess the injury, look at where the opening is, and try to provide local pressure. So this was provided again by some friends, and you can see that they're really keeping their cool when they're doing this. You see the visualization with the endoscope. They're trying to cauterize. This is not a full carotid injury, but a branch, so they're trying to cauterize it, etc., etc. Ultimately they did gain control of that injury. So I want to mention also some secondary effect of nasal packing, some consequences that are kind of unexpected. So I don't know how they were able to complete this study, but it is an amazing study. They have 12 carotid injuries that were treated with nasal packing with immediate angiography to follow. And you can see here what happened with the nasal packing. About 2/3 of the injuries, the carotids, were totally occluded. About 1/3 were partially occluded. In one case, the middle cerebral artery was totally occluded, and in one case, even the basilar was totally occluded. And of course, you have some of these patients that have multiples in this. So their conclusion is that overpacking, not packing, overpacking, contributes to the mortality and morbidity of the patient, and that is true. So we have to have this in mind, and that's why we like to observe the point of injury of the carotid at all times possible, and provide just focal pressure. The other things that we have to consider is good to have an anesthesia team that is versed in this type of things. Here in Ohio, we're very lucky. We have a neuroanesthesia team that has saved the day multiple times, so they are versed in blood transfusion and resuscitation. So the idea of this is to stop the bleeding while we maintain cerebral perfusion. There have been some advocates in the literature for digital compression of surgical control. I think that this is one of those things that in theory may work, but in practice is very hard to do. You will have two surgeons working frantically to stop the bleeding inside the nose, and then you have to have a third person coming beneath the drapes and try to apply pressure on the carotid. It's really not very practical. So for those of us, especially ENTs, that we love hypotensive anesthesia, this is not the time to do it. You will impair cerebral perfusion even more, and if you don't stop the bleeding, the patient will be hypotensive enough anyway. The use of heparin is counterintuitive. Use anticoagulation for somebody who is exsanguinating. It may seem like a bad idea, but it's actually not. It's actually a good idea. The issue with the heparin is try to prevent embolic phenomenon that may happen when you injure the intima of the carotid artery. So 5,000 units of heparin is not going to make the patient bleed any more or less. The patient is going to bleed just as much as the hole and the blood pressure allows. And again, you have to stop the bleeding. So this video was provided by PJ and Rowan Valentine from Australia, and they have developed this sheep model where they actually put this plastic model imitating sinuses over the neck of the sheep, and they actually injure the vessel, and you learn how to stop the bleeding. Now, it's a great model, although it's very intense in the use of resources. But from this model, they were able to yield some conclusions that are very important. You will see always that there's one side that bleeds more than the other. So you're going to put your endoscope in the side that provides you the better visualization. You have to also realize that blood has some capillary adhesion, so you can see that the blood tends to run over the suction and will tend to run over the scope. So hovering that suction over the blood works much better than just diving the suction in the pool of blood. The use of large bore suctions is really important, and something that we never talk about is that you have to make sure that your nurses keep the suction canisters open and the lives patent and functional, otherwise it's the same as having no suction. The use of muscle patch, they have demonstrated that is a great technique, and so usually is muscle that has been crushed, it has been compressed, injured a little bit, and this is why we prep the thigh. You can take muscle from different parts of the body. You can take muscle from the SCM, but again, getting to the neck is not an easy thing. I have seen in the literature even muscle from the tongue. That to me is a little bit crazy. You add contamination and you add functional problems down the line. You can use abdomen, but the problem is that if you have an elderly patient, their abdominal wall may not be as strong as you want, meaning that the source of muscle may not be as thick as you think. If you go to the thighs, you will always have enough muscle, even in the most elderly patient. So muscle patch, applying the muscle at the area of injury, you have to hold it in place for quite a few minutes, up to 30 to up to, I would say up to 40 minutes for it to work. Things that they found that is ineffective, Floseal. Floseal is actually very dangerous. Floseal can go into the circulation and cause some problems. I have seen several problems with that. Other things like chitosan and oxidized cellulose did not work for this. Now, similar results to the muscle patch have been suggested for fat, muslin gauze, and complex polysaccharides patch. But again, I think that muscle is the most reliable technique and is available. So, and that's why for most of our cases, we actually have the right thigh of the patient available and prepped. So once you have controlled the injury, we will take the patient to the angiography suite. What you have done is something that is a temporary patch, and the angiographer is the one that is going to save the day. The idea is to try to preserve the carotid flow, so the use of pipelines or cover stents is better. In some patients, that's not going to be possible, so they will have to sacrifice the carotid, and that's when a balloon occlusion test comes into play. You want to know that if the patient needs that carotid completely or if you have to do a bypass. And once you have done that, the management doesn't stop there. You have to transfer the patient to the neurological ICU. You have to have a strict blood pressure control, anticoagulants if they put a stent, etc., and a delayed angiography, which we don't know when is the best time to do it, but we decided to do it at 7 to 14 days after the injury. And the idea of this is to identify things like a pseudoaneurysm or a carotid cavernous fistula that may form in a good proportion of these patients. So again, you have to control the control of the injury is from all these things that we have been talking about. Luckily, we have some training models nowadays. Here's the Simont by Aldo Stam. Here's the Gabi Sara that uses a cadaver. The Simont uses a plastic model. The USC or Sara model uses a cadaver, and so we have basically tempera coming out, acting like blood, and it's very real. You can see here that it looks just like it. And then you have the Valentine and Wormel model that uses a sheep. Now, the great advantage of the sheep is that it's a live model, so you can actually see how the muscle works. But of course, it's resource intense. It requires a lot of resources to be able to do it. We also have a plastic model that we created here at the University of Ohio. It looks very real. It doesn't, of course, is not as realistic as the cadaver, and you cannot do coagulation, but it shows you how to maintain visualization during the injury, and you can do it anywhere. It doesn't really have the implications of a cadaver model, and that is commercialized by a Japanese company. So we have done validation on whether training makes a difference, and it does. You can see here that after training, the time to hemostasis decreases significantly, the volume of blood that you lose decreases significantly, and this also has been validated by the sheep and the cadaver model, and the level of confidence goes up. It gives you that level of confidence that you will be able to deal with this. So this is a carotid injury protocol that we have published in the past, and what I want to emphasize here is that we always talk about what happens in the operating room and the surgical model, but we never talk about what happens after that, and that's just as important as what happens in the operating room if you want to have a patient. So what happens in angiography and what happens in the intensive care unit is really critical. How are we doing with time?
Prof, you've got about 5 minutes left.
Okay, so let me show you this case really quickly, or the main issues with this case. This is the case that we injured the carotid and the paraclavial carotid. What I want to show you is really what happens afterwards, because I think it gives you an idea on how important. On this particular case, we packed it with muscle. We put some cottonoids and this balloon, and we transfer the patient to the angiography suite. Remember that it was extradural. So in the angiography suite, they found that the patient needed that carotid. They did a balloon occlusion test, and they put a pipeline. And everything went very well. They put him in Plavix and aspirin, and everything is dandy, except here you have after the occlusion, the pipeline stents. Patient is doing great, and we're going to take her a few days later to the operating room to really, you can see the stent there, the pipeline, to remove the packing. And while the resident is taking the consent, the patient just strokes right in front of them. Oh, by the way, before that, we have a drop in hematocrit. So we found out that the patient had a nice hematoma from the angiography and embolization. The patient had to be transfused. So now we have this stroke. And it's in the contralateral. Let me stop here for a second. The stroke is in the contralateral side, and it's a hemorrhagic stroke. So the stroke didn't happen because of the injury. The stroke happened because of the anticoagulation. So here we take the patient again to the operating room. We found there was some bleeding that we thought it was a carotid. It was not. We put more muscle at that point. If a little bit of muscle is good, more muscle has to be better. So we packed her again, and then a few days later, we went back and removed all that. Let me just go to the end here. I guess I do not have the end. But anyway, that's this patient had a hemiparesis that persisted for quite some time, never recovered completely, and that's that one. So let's see if we can see this one very quick. We'll show you the main events. Yeah. So here's a patient that is a chordoma, has been operated 4 times. He has been given proton therapy 2 times, a stereotactic surgery 1 time. So you know that you have a very high risk of injury. And I want you to pay attention when the injury happens. We know where the carotid is. It's right here. So we're dissecting behind the carotid with a very blunt probe. We're just displacing the carotid laterally, and boom. So to make the story short, we're there trying to stop the bleeding for a long time. We have muscle, and here we're holding the muscle in place several times, and it doesn't stop. Actually, every time we try to take the pressure off the muscle, it bleeds more and more. So we finally decide to pack it and go to angiography. So here you can see the main issue is here's angiography. The angiography. She has vasospasm on the initial angio, which I guess is bad, but not too bad. He's bleeding less. But while the angiographer is trying to put a stent, you can see what happens, right? So they burst the carotid. They almost separated the carotid completely, avulsed it. After a lot of struggle and 8 liters of blood loss that the anesthesia team was able to keep with, they are finally coiled the carotid. So they sacrificed the carotid. And luckily, this patient had no problem after the injury. And a few days later, we took her back to the operating room to remove the rest of the tumor as much as we could do. And I'm gonna you can see the coils of the carotid. Obviously, that's a coronary spasm type of case. We are able to remove the tumor that was compressing the optic nerve 3, the 3rd optic cranial nerve. And after that, the patient has had multiple complications regarding treatment, mostly from the radiation therapy, and she's not doing very well, unfortunately. But she was neurologically intact after that event. So with that, I'm going to stop my sharing, maybe entertain any questions you may have.
StealthStation ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, StealthStation ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB, or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With StealthStation ENT, you're at the forefront of ENT surgery. You are Stealth.
Thank you very much, Prof. I had about 30 minutes of palpitations watching your videos.
They are definitely anxiogenic. Yeah, every time somebody sends me some of these videos, and I have about 10 more that are even.
Oh dear, I'll get a heart attack, I think. I still remember my very first ICA injury, and it's a shocking time. And I just wondered, obviously these complications don't occur on a regular basis, but are you less stressed when it happens now than say 5-10 years ago?
I am. So it's not that I'm not stressed. Don't get me wrong. This is not a casual type of thing. But I have dealt with it. I have trained in all these models that I showed you before. And my confidence that I can do it is better. So I know that I have to talk to myself to keep calm and to keep my cool and the whole deal. But I know it can be done. It's not. And it can be done reliably. You can repeat the same event and with the same type of result. So yeah, I think that I can deal with this much better. It's like what they were showing before with an angiofibroma, right? The angiofibroma are really challenging cases, but as you do more and more,
correct,
you basically develop the tools to deal with them.
Am I correct to think that the team goes into auto mode when one of these complications occur?
Yes.
They have to, isn't it?
Yes.
Because you have to overcome the anxieties and the stress, yes, and get the entire team into auto mode.
Yes, so it's really amazing because some of these injuries happen in the neurosurgeon's hand, some happen in on my hand, and we count each other. We come, yep, and hey, yep, we just talk to each other. So everything is going okay, yeah, just put more pressure there. They're doing great. All that type of thing works. Yeah.
And that underscores the kind of relationship that we need to have with our colleagues, yes, especially when undertaking endoscopic skull base resections, isn't it?
Yes, and this is a whole team. This is not just, yes, the neurosurgeon and ENT. This, yes, is really the operating room staff, the anesthesia staff. I mean, you can imagine somebody bleeding 8 liters and coming out at the end of it completely intact. I wanted to go and hug the anesthesiologists because they did such a fantastic work trying to keep up with the bleeding.
That's so true. I'm just scanning the Q&A and the chat lines, and all 370 participants, I think, found out that you had a very busy on call last night. And out of respect, they've not asked any questions. And I suspect they're all wishing you a very, very restful sleep
Sam,
this weekend.
can I interrupt you?
Yes, of course.
Rick, thank you. That was excellent presentation. very helpful if you are landed in that situation. So we just did a delegate poll, and we asked the question, does your institution have interventional radiology support if you're doing these surgeries regularly? I think 36% have a day and night on site. So can you see the poll on site, Sam?
Yes, yes, I saw the poll, yes.
Okay, so yeah, that's interesting. I think that support is very important.
Yeah, thank you.
Thank you.
So maybe before I leave, I would like to introduce the next speaker because we have a long-term relationship, and I have seen his career develop from being a novice surgeon for somebody who's just starting to somebody that has become an expert. And we always talk in medicine that teaching is a two-way street, and Janakram is the epitome of that, because now he has come back to teach me about many of these things and many of the techniques that he uses for the resection of tumor. So without any more ado, I apologize for having to leave you guys, but congratulations again for a great set of lectures and presenters. Thank you.
Thank you, Rick.